topic for the same is how to equip with e-health infrastructure to ease the adoption of medical treatment beyond geographical boundaries. The panel speakers for the same are Dr. Aloke Mullick, Group CEO of Omni Hospitals, Mr. Sameer Mehta, Vice Chairman of Dr. Mehta's Hospital, Mr. Bharath Kanth Reddy RY, COO of KIMS Hospitals, Dr. Sujit Chatterjee, CEO of LH Hiranandani Hospital, and Ms. Gouri Sardesai, Vice President BD of Lokmanya Hospital Group of Hospital. She will be our session moderator for this panel. Hand over to you, ma'am.
Thanks a lot. So years back, we were talking about the cross borders who always wish that there could be a right diagnostic before they travel to the next destination. And it was not possible because they had to come all the way. They have to come to the particular destination, and they would understand, okay, this doesn't need a surgery, it's just a conservative treatment, and they used to get their solution from it. With the pandemic, e-health was accepted, and today we are here on this platform to understand from the healthcare leaders how to equip with the e-health infrastructure to attend medical treatment beyond geographical borders. So, my first question to my guest, to the panelist over here would be, how can you maximize the use of technology in healthcare to ensure equitable distribution?
Gouri, you need to take somebody's name so that they can answer it.
Yeah, Mr. Sameer Mehta, can you put some your views over here?
Actually, the simple answer is you pay hospitals to use the technology, but the harsh reality is the technology companies expect to be paid by the hospitals, and I think that's where the crux of the conundrum. In terms of what a consumer will benefit from, what a hospital gets paid for by an insurance company, and more importantly, what a technology company believes from the healthcare institutions have a degree of incompatibility in a large set of cases. As of today, a lot of hospitals are hand-to-mouth survival because of COVID, uncertainty, because of the number of cases that have started slowly coming back for elective surgeries, but still have high degrees of uncertainty because we've obviously had to live in a very strange world. So I think the correct answer is if you can find the right incentive mechanism for a hospital to use technology, there is hope. The problem is in today's light, the moment the core need disappears in the short term, the hospital is there scratching its head because there is nobody in a hospital who can champion technology and spend a high amount of capex or a significant amount of opex where there are thin margins. That's my view. Thank you.
Okay. Anybody else who can put, yes? Anybody else who can add their views over here? Mr. Bharath.
I'm Dr. Chatterjee from the Hiranandani Hospital, if I may just add.
Yes,
today we are in a position where we can't do without technology, as far as hospital ops are concerned, and there are many things. There are many examples. For example, today, if you have to have your prescriptions electronically done. For example, in the OPD scenario, you can have your prescriptions captured, you can have all the data captured through software, and this can be stored in the hospital. And if a patient, like you're talking in terms of geographical boundaries, that we cross these geographical boundaries, then all it requires is a simple email to send your prescription across to the place that you are in, and you can there consult another doctor, and there will be no disruption in the the way the prescription has been written, or even the clinical findings. So I think it's extremely important to understand that today people are traveling. Geographical boundaries have ceased to exist. And I mean, of course, if you know, geographical boundaries exist between Ukraine and Russia. But the point of the matter is that if I need to travel somewhere in Europe and I require you to send me a mail with the last visit that I had in, say, the Department of Cardiology, I should be able to do that. So the only thing that I think is where we need to stress is upon the the sort of security and the privacy. If that is 100% guaranteed, then I think these sort of technological advances are extremely important, and e-health in its entire paradigm will be addressed. Thank you.
Thank you, sir. Thanks a lot for your inputs, for your views. Can anyone else take this question?
Actually, what Samir said is very spot on. Lots of small hospitals or big hospitals, like big hospitals, have huge budgets, and even despite that, many hospitals struggle with the adoption of technology. That's a very different piece altogether. But lots of small hospitals struggle to budget for technology. I mean, they work on small margins, and technology companies do want to be compensated. And so ultimately, it's a chicken and egg. Some hospitals decide that, okay, we'll create our own products, and they end up doing a good product, many assigns. But then ultimately, we don't have a choice. We will ultimately need to adopt technology in a seamless manner. I suggest all healthcare leaders, at least in my organizations, to read a book called The Patient Will Now See You. And the future of healthcare will be alone the mobile space. If your hospital is not in the mobile, 5 years from now, it will be irrelevant. So the way, I'm sure all of you know, Amazon has started selling medicines on the Amazon app with a flat 15% discount.
Yeah.
All these things are coming. These things are disrupting the industry. So if your hospital doesn't have an app on which the patient can see his blood reports, his trends, his discharge summaries, his diagnostic reports, as early as 2 years from now, you'll be history. So we need to figure out how to budget for this. And smart investors, smart promoters are budgeting for it right now. And many hospitals that I know, including my own, have major technology initiatives in the work. They are either getting it made for third party, or they are doing it themselves with their in-house technology team. If you don't do it, this will come back to bite us in a few years from now.
Thank you. Thank you very much. So now that we have understood how to maximize the use of technology in healthcare to ensure equitable distribution, may I ask Mr. Bharath, Kanth, to understand, us know your views in the India. How far is the Indian healthcare system equipped with the technology to extend the scope of research and treatment?
Yeah. Good afternoon, all of you.
Good afternoon.
And see, as e-health, which is originally aimed at providing the accessible healthcare to all the people, has moved into a totally different scope of work now. The people who are in remote areas were actually planned. So with this, the government of India, if you see, as what Gouri has asked me, is the Indian healthcare system equipped? Yes, we are, not fully, but yes, we are in the process of going in that style, in that fashion. See, it's like COVID has thrown so many challenges. Before even the government or the healthcare could act on it, actually, even the people are equally participating in this and taking the healthcare facilities to the next level. Now, here, what I have to say is, the hospitals which were actually not fully equipped or were not interested to equip with the new technologies were forced to take over the technology because of COVID. And after that, now recent budget, wherein our National Health Mission, there is a plan to create a database of all the people. With this, if Niti Aayog and Ministry of Health get into the consensus, then definitely yes, we'll be moving in those lines. Yes, go.
Okay, thank you very much. So, Dr. Sujit Chatterjee, what do you think? Are we equipped with the technology to extend the scope? My question to you is.
Gauri, I think let us invite Dr. Anupam Karmakar for his opening remark and then move again with the second round.
Okay.
Dr. Anupam Karmakar is not there.
Okay.
Yeah,
Okay. So we are with 4 speakers then.
Yeah, we are with four
Okay.
speakers.
Okay. Yeah, please go ahead.
Yeah, so my question to Dr. Sujit Chatterjee was, again, what is your view? Is this Indian healthcare system equipped with the technology to extend the scope of reach?
Yeah, well, it's a question which, sort of limits on comparison. Now, if you're talking to me in terms of am I equipped with technology as far as the United States are concerned, or we're talking in terms of, some of the Norwegian hospitals are concerned, then we have yet to reach that level of sophistication. But if you're telling me about, routine things, like, for example, hospital information systems, or if you're talking to me in terms of picture archival communication systems, we are talking to me in terms of digitized formats of transmission of images, you're talking to me in terms of teleradiology, you're talking to me in terms of teleconsultations, you're talking to me in terms of transmission of ECGs from remote areas of patients who are being transferred to a tertiary care hospital. All of that is absolute passé. I mean, it's all there, and it's been there for many a year. So therefore, the question really is that are we doing routine work as far as technology is with technology? We certainly are. Who says we are not? And we are certainly not backward. We are very well entrenched with these systems. We're very familiar with these systems, and it is being utilized in a very, very large extent. For example, today you have automated laboratories. You have different types of machines which are all linked together by a middleware, and the results from various different machines are taken by that middleware and put into the local area network for anyone to access. So therefore, if you're talking in terms of biochemistry, you're talking in terms of serology, you're talking in terms of immunology, the entire patient data in a comprehensive manner can be sourced at the click of a button. Now, isn't this what we are talking in terms of? I think we're already there. But if you're talking in terms of are you as advanced as, say, the Scandinavian countries, well, the answer is no. Are you as sophisticated as America? Well, the answer certainly is no. But, if you're talking in terms of anything in Asia, India is certainly there with any of the drivers as far as our continent is concerned, and maybe a little more advanced than any of the countries in Asia. That's my opinion. So therefore, I think we are very much there.
Okay, thank you. I'll add a question to you. So you say we are very much there. Right?
Yes.
Yeah, but I think there is some percentage which is lacking over here. Do you think there is some percentage who are using this technology, who are equipped with this technology, or who are implementing it, and some percentages are not?
Yes, you're right. You can't have a very large percentage of healthcare using it. For example, if you're talking in terms of, tertiary care hospitals, they certainly would be using technology. But if you're looking at the, broad bandwidth of healthcare in India, so let's talk in terms of secondary and primary level of care. In the secondary level of care, there is certainly a drift towards, if I may add, the municipal hospitals, the government hospitals are imbibing technology for enhancing their work. But where we come up short is rural medicine. So therefore, there are schemes which the government is trying to push through. There are a certain big, large healthcare groups who are already, testing their electronic healthcare configurations across many centers which are primary, which render primary healthcare. So therefore, if you're talking in, tier 1 cities, I think we are good, really, really advanced. But if you're talking in terms of tier 2 and tier 3 cities, then yes, there will be a certain amount of lacuna. But the real lacuna is in the districts. I think there, if technology is sort of pervades into the districts, then India's healthcare, the overall healthcare, our maternal mortality, though we've improved it, there are two fundamentals in the quality of healthcare. That's your perinatal mortality or neonatal mortality and your maternal mortality. So therefore, while we've been able to reduce it, we are on the same level as, or a little better than maybe Bangladesh. So that's the real area of focus. But if you're talking in terms of Mumbai, or you're talking in terms of Delhi, or you're talking in terms of Kolkata, Chennai, Bangalore, we are done and dusted. We are right there. We are right there on top.
Okay, thank you. So having said this, we are still we can see the gap. So my question to Dr. Aloke Mullick is, what strategies can be implemented to improve the nationwide access to of e-health? Dr. Mullick?
Sorry. So our best help was in COVID. So suddenly everybody started becoming fond of technology. The patients they don't want to see physical reports. They want to go to the hospital. And nearly 25% of patients can be treated remotely. So that is taken off. But we need a lot of legislative push. Now, we're talking about technology, we're talking about continents, but the internationally accepted method of technology adoption is the EMR adoption model of HIMSS. And as per the HIMSS adoption model, India is woefully down in the bottom. Just probably half a dozen hospitals which are HIMSS level 6, HIMSS even level 6, forget about level 7. And technology comes expensive. So there has to be a characteristic from the government that the way we did it for NABH, okay, you are NABH certified, you'll get 15% extra revenue. If you're not certified, you won't get that 15% and you might be penalized also. So that the government has been threatening to do for the last 10 years. It has not yet happened for whatever reasons that the government would know. But unless that happens, hospitals will continue to work the way they are. Doctors will continue to work the way they are. And the bright side is doctors and hospitals which have adopted technology, there are at least half a dozen HIMSS level 6 hospitals in India. There, the doctors will never go back to paper. Will never go back to paper. After that, once you are fully paperless, It's very easy to expose that data to the patient through an app. It's very easy to analyze that data and do population level statistics, do AI and come up with newer treatment methodologies. But first, you need to digitize the data. You need to have a proper international level EHRs. All those applications are available in India now by Indian vendors. We need not pay 5 crores a pop for an international EMR, but still, unless the government steps in, puts in some sticks and carrots, hospitals are not going to adopt it. Even for a bread and butter HIS, a decent HIS for a 100-bed hospital will cost anywhere north of 20 lakh rupees or 30 lakh rupees. And you get a hole-in-the-wall vendor coming and telling the hospital leadership that मैं 5 lakh का बना के देता हूँ, and they'll take it. So, and this will be some crap code which will collapse within 1 year, but they will try to save money. So that is the way IT budgeting is done in India, unfortunately. And unless the government steps in, government has already, by the way, created a national EHR standards handbook. It is in version 2. So and version 3 is about to be published. So the understanding was that ultimately the government will mandate, government will create a system of an agency which will check, okay, you have a EHR, is it as per our standards? If it is as per our standards, you will get the following benefits, but he has yet to happen. Till that happens, I'll see more of the same continuing to happen. We are actually in technology adoption very poor, as per international standards.
So what do you think about the pandemic thing, which changed the picture in the
pandemic? Is just people have started doing telemedicine. That's all.
So don't you think that the pandemic changed?
And the commonest, by the way, the commonest way people are doing telemedicine is WhatsApp video calls.
Yeah, correct.
That's how telemedicine is happening in India. Individual consultants doing WhatsApp video calls, writing prescriptions on their pad, taking a picture and sending it by WhatsApp. That is technology in India today.
Gouri, Dr. Mullick, if I can add something to this, as you were saying about the EMR and the HIS which are available. So if government can step in and say that integration of all the EMRs or all the systems which are being used in different hospitals, that can help in one way. That could be one of the strategies. And there is one important thing which, me being from Hyderabad, in Genome Valley, government of Telangana is actually encouraging for the integrated rapid diagnostic testing devices, not about the rapid testing, which are the portable devices. So if these are given much encouragement and given access or is supplied to different parts of India, the information what is collected from these devices can give information to the practitioners. So this could be one strategy wherein the medical care is sent to different parts of the remote areas. As what Dr. Sujit Chatterjee was saying, the government or the India is equipped, but only the urban India, not the major part of rural India is still not equipped. If we can provide this access, so that would be one of the important strategies for us to take this forward.
Okay, great. Thank you so much. Thanks a lot. So for my next question would be, as a healthcare professional, do you think experts and caregivers in India will get used to the e-health system in the future? This question may I ask to Mr. Samir Mehta?
Yeah, thank you. Look, I think a lot of caregivers have been exposed to technology in the last couple of months, right? But the reality is the amount of uptake, it's a little bit like what we're talking about. It's a chicken and egg answer. So if you make it hyper convenient and hyper useful for them to get the software on the fingertips, like what WhatsApp is, like what Skype is, like currently email on a phone, and it's very, very low cost, because the problem in India is we are not we are over optimized to serve the masses. We are not over optimized to serve high value solutions. That is not what India represents and should never be, right? I think this conundrum of let's be exactly like America, it's like expecting first world outcomes with third world pricing, right? And we are not a third world. We are a very different world. We are India, which means that we are solving masses, which is a much more important and relevant thing than where we are overpricing and being highly inefficient at systems. So for care, I'll use one simple example. We have a technology that does the eICU. And what care workers found that the technology of eICU wasn't the most useful thing, other than the fact that you got very accurate things on the mobile phone. But the killer use case for that was when an individual caretaker, a doctor or a nurse could put the alarms for each monitor by the patient. So let's say you've got a deteriorating, having an SpO2 alarm that drops under 95 for the duty doctor versus for the head of department that's at 94% SpO2 versus the nurse who's on the ground who has to have obviously a higher threshold. So 96%. So that escalation protocol made that the nurse never wanted to be told off by the head of her department or the doctor. And so therefore that use case of having highly custom alarms on top of the technology made the uptake go from effectively what was about 30% of caretakers using it to about 98% of caretakers using it daily for every patient, right? So I think it's the overlay on top of existing technology, because all the tech really exists today, if we're honest about it, that makes life a lot simpler and a lot better for the person on the ground in the front line. I think if we can solve that and we can do it well, it's hats off. And I have to say hats off to the company that did it for us, Health Sensei, because they actually thought through that by talking and sitting and interviewing nurses, duty doctors, the head of department. And the head of department said, Sunday night during COVID, I'm not sure who's going to come on shift because nobody wants to come on a Sunday night, right? And I don't know which nurse will catch COVID this month. And therefore, I have to make sure that there is a overlay that protects me at risk from a customer. And all overnight with a technology solution, we were able to solve that. Thank you.
Thank you. So, Dr. Sujit Chatterjee, may I ask you, sir, that as a healthcare professional, do you think it's very easy to get used to the advanced e-health system, or how it is, which will be coming ahead in the future now?
It depends upon the generation, like my generation, for example. Me, for example, I may not be very tech savvy, but the newer, kids on the block, they are tech savvy and they will be using technology, and there may come a situation where you have generation next, that is, 2 generations away from me, who may not even work without technology, and they will be so used to it. So yeah, for sure, doctors will definitely be able to use technology. You see, we always crib about the fact that we are not able to, enter. We are not able to, it's easier for me to write and see 5 patients at the time that I will be able to navigate through an EMR. But there are EMRs where you have drop downs. It's just a click of your mouse and you're able to capture data. So therefore, people who are, the youngsters who've grown up playing video games and stuff like that, they would be very, very quick at it. So I'm absolutely certain that the future will see doctors very, very tech savvy and using technology. Yeah, sure.
Thank you so much. My question next to Dr. Aloke Mullick is, are there changes in the way healthcare technology is getting adapted post-COVID? Do you see some changes in this?
Oh, yes, certainly. I mean, lots of people are rushing for telehealth solutions. That's one change which has definitely happened. But one must understand that telehealth is a very small part of technology, right? So it needs to go to the next level. But the happy thing is that many hospitals are realizing that technology is the future, and they have started budgeting for it, as I said. And they have started creating projects and programs for the future, which will mature maybe 1 year, 2 years, 3 years from now. Bharath was talking about the Genome Valley. In fact, some of the top medtech hardware producers are very much here in Pune. There are companies, medtech. When I say medtech, I mean mobile medtech. So a big future is home care and remote monitoring. So some of the top internationally certified remote monitoring device companies are here in Pune, and we are actually talking to 3 of them. We have identified a home health remote monitoring platform, which is based out of Dubai. And at the moment, as we speak, we are integrating these devices with that platform and rolling out a business case based home health solution to thousands of patients. Now, that is something that hospitals have understood, that technology is the future, not all, but some. And as these hospitals, which are the trailblazers, they show that technology can be adopted with a win-win for everybody, where the patient is also happy, the doctor is also happy, the technology company is also happy, and you're not making a loss. That will encourage other hospitals to do so, right? Now, a new breed of EMRs is coming up in India, all made in India, most of them made out of Bangalore, which are totally mobile-based. You don't have to click or drop down on this, and they have a mobile UI. You can, they have voice tech, very high quality of voice tech, which is tested in ambient OPD noise. He's seeing a patient in the OPD, there is an ambient noise. He speaks into the EMR, into his mobile phone, and it takes down the clinical finding. So all that stuff is happening. The only thing is taking some time. That's why I said the government needs to push. If the government needs to push the way the government pushed in America. Before government pushed in America, American HIMSS adoption was pathetic, just like India today. But within 5 years after the government push and checks and this carrot and stick, 65% of American hospitals are in the upper HIMSS level, 65%, right? So that there has to be some characteristic which coming from the government. It will people will start adopting it further. Right now, early adopter hospitals, I know many of them personally. They have very interesting programs around technology, very, very interesting programs, and these will hopefully encourage other hospitals to do so. Thank you.
Thank you very much. Now, when we say that, okay, the technology, the healthcare technologies is there are medical professionals who are also ready to accept it. There are people also accepted after the pandemic thing. My question to Mr. Bharath would be, do you think that there are still blocks in accepting this whole e-health thing, or people have, like as I asked before to Dr. Sujit as well, that probably there is no 100% acceptance to this. He was saying about the tier 1 cities, yes, Mumbai, yes, Bangalore, or yes, Calcutta must be accepting it, but I think even there are still some blockages.
Yeah.
What would be your view, Doctor?
Just to take all of you back to when was e-health started in Hyderabad, or India, in fact. In probably 2001 or 2000s, Apollo has started with this e-health, connecting Dr. Pratap Reddy's hometown, Apollo Aragunda, with Apollo Jubilee Hills. But because of some reasons, that's where your question comes, Gouri. It was not so high, it was not so good. The acceptance was not that high. Now coming to now, as what Dr. Sujit said, yes, that at that time the doctors were not so much keen on working on the computers. and taking the feedbacks. And the patients also wanted to come and see the doctor in person, and the doctor wanted to see the patient in person. Now here comes two things. One is about the second generation next medical practitioners, and at the same time is not that the medical practitioner himself, the doctor himself, does all the things related to the e-health. As Dr. Aloke said, e-health is not just telemedicine. The people who are supporting the consultant in this practice, the nurses, the technicians, and other staff who are there, should be given equal training to handle this. So unless this is done, these people will not support the consultant, and the whole program will not be taken forward. And the next one is the most important thing, whether the patients themselves will accept this. Here comes the question of the data privacy. What about my data? I am sharing all my data. So whether this data will be the vital data, will this be safe when I share with different people? So this where ICT protocol and NHS protocols comes into the picture. If all these are done, if the employees, if the manpower is trained properly, and they are given a device, or they are given a platform which is user friendly, and patients are given the assurance that your data is safe with us. And at the same time, we have to, when we say we as all the healthcare professionals, private, and then even the government has to create awareness that this mode is also an important mode wherein you can get the same treatment by being at your hometown or being at your home without actually visiting a tertiary care hospital. Now, future, as already being doing, Apollo is doing, NH is doing, and Fortis is doing augmented reality. If that comes into the picture and all of them can accept this practices, here again comes, as what Dr. Aloke said, the budget. So every hospital cannot afford to do that. So these could be some problems which, though we are saying this is the new normal, but accepting this new normal needs a lot of awareness, needs a lot of motivation, and at the same time needs a lot of training and financial support and the knowledge support to the participants. This is what I have.
Okay. Thank you very much. When you said assurance, I immediately recollect Dr. Sujit. He mentioned that maybe 2 generations from now, the kids who are tech savvy can use this technology, or you can easily adapt e-health. But again, when you spoke about assurance of the patients that the patients won't be comfortable or may be comfortable after even assuring them that okay, these things might this is for you, this everything will be confidential, and it won't leak anywhere. So you being a very senior doctor as well, I want to have your views. Do you think that the patient would be really by saying this, that be assured your data is very confidential, we can have a teleconsultation and we can understand what is your problems, and let's clinically they will be able to describe or tell you on a call or a video call about it? Dr. Sujit. Hello.
You see, it's like this, is that in medicine, if you do not examine your patient and there is no clinical examination, you're likely to miss a lot of very, very common diagnoses. You must be able to see, you must be able to examine and palpate your patients, as well as, do a general physical examination, a systemic examination. If you really want to come down to a clinical diagnosis, history is also extremely important. See, technology always will aid something which is basic. I am not saying that technology is going to replace your bedside clinical medicine. It just cannot. Medicine is such a science where you need to be with a patient. You need to see. I mean, there's no point in sending me, this is the patient's temperature, pulse, blood pressure, etc., when I have not even had a look at the patient. For example, if you have a patient who's got, third pace sequestration of fluid because of septicemia, and your answer to that on imagery is, okay, I'll fire Lasix. Well, that's not the answer. The answer really is that you should be at the patient's bedside. But then again, it has to be matched with technology by which you can send samples of investigation and get the result at the patient's bedside in a very short point in time. So that is exactly what laboratory information systems are all about. That is exactly what middleware is all about. And that is exactly where your local area network comes in. So therefore, to answer your question is that no patient is going to be satisfied if they cannot see a doctor. The doctor doesn't, have a bedside examination. How will a person diagnose anything without a bedside examination? You talk to a cardiologist, you can't just put a stethoscope and say that, okay, all is well or all is not well. I don't think that's ever going to be replaced. But the fact of the matter is this, is that if I have a method by which, say you have COVID and you have a cardiac patient who's got a murmur, and I have a method by which I can hear the murmur off-site, I am in a position to diagnose something. But to able to see pallor, to ask him to put his tongue out, or just to touch the patient and make him feel better. How can technology be replaced by clinical medicine? It is not. The idea of technology is to make clinical medicine easy. The idea of technology is not to replace clinical medicine.
Thank you very much. Thanks a lot. So my question to Dr. Aloke Mullick will be, how much percentage of technology will be helping us? Because even you are a doctor, sir. So what percentage you think will be helping us? The e-health will be helping us?
Most of the technology, newer technology that is coming up are consumer facing. It makes life easier for the consumer. Today, the consumer is demanding that if I have to buy a fridge or a box of cookies, I just go on an app and I get it and it gets delivered. Why should I have to call a hospital line, wait in a queue to pay money, all that kind of, and spend my whole virtual day just for a consultation? Why can't it be done online? Why can't many things, lots of repeat visits can be done online? You don't need to, you don't have to just show up to a doctor's office just to show a blood report, which was ordered yesterday. So many studies have shown that nearly 25% of a consultation which are physical can easily transition to online. But it's like consumers have to carry all their lab reports and this and that and all that nonsense in a file. Why can't they carry it on a PHR? Consumers have started asking that. And hospitals which are able to do this first will reap the benefit. Definitely, they will be considered as patient-friendly. Now, so the initial thrust of technology will be to help the consumer, to ease access to information, ease access to accessing care. Now, the second thrust, which is all work in progress, it is in highly evolved societies, it's already there, is AI-driven care. And lots of things which are being done manually today are being done through technology. Patients are being operated remotely through robots on the battlefield. This is being done in the US Army. The patient is in Baghdad and the surgeon is sitting in US and he's being operated remotely. All those things are happening, right? It has been demonstrated when the first time when robotic surgery took place, or say laparoscopic surgery took place, everybody laughed at it. We are old-time surgeons, and I'm sure Dr. Sujit will agree with me that we all laughed at the advent of laparoscopy, but ultimately it became the gold standard. Ultimately, robotics has become the gold standard. Similarly, newer technologies will evolve. There's a joke amongst cardiologists which goes like this: how do you find out whether this cardiologist trained in Britain or trained in the US? The guy who's trained in US will not carry a stethoscope, right? He'll say, okay, show me your to the echo report. So that's the way technology, healthcare is evolving. Whether for good or for bad, it is coming to stay. Lots and lots of new generation doctors are totally dependent on technology. They've forgotten the art and science of, as Dr. Sujit said, putting a hand on the abdomen. And because they feel that technology helps them, and in many cases it does. One of the first softwares to be written, medical software, was for arrival of some nuclear submarine, where there was a surgeon, and he didn't want to do a negative lab for a suspected cholecystectomy, a suspected appendicitis. So he said, okay, I don't want to open up the case. So the software was written to guide him to avoid a negative lap, because in a submarine which is submerged, and you do a negative lap, the unnecessary lap to come up and those kind of things. So right, technology is helping. Medical science is going forward. For better or for worse, is for posterity to decide. And we are the old timers. For us, putting a hand up the abdomen is the gold standard. But you ask any blue-eyed boy passing out of a new med school in a tech-savvy country like, say, Israel, he will laugh at us. He say, "Okay, you guys are old hat, right?" So,
correct. So, to the audience,
incidentally,
yes.
one more point. I hope just to show where technology is heading. Now, there's this AI-driven app called Babylon. Any one of us can download it. Now, Babylon has, in many shootouts, has actually defeated Royal College certified doctors, physical doctors, in diagnosing actual patients. Now, it's an AI app, right? Now, Babylon has been certified in China to be used as an online doctor, and prescriptions as a primary care physician, prescriptions created by Babylon are accepted in a pharmacy. Babylon is used for remote area people who don't have access to doctors. In India, at least 3 states are considering legalizing Babylon, right?
Okay.
Now, Babylon, one of the core developers in Babylon is an Indian. They're all British based, they're all England based. Now, so technology is moving that way. Here is an app which will actually diagnose you and give you a prescription. Go download it and check it out today. It's amazing.
Okay. Thanks a lot for this information, Doctor. And I would thank all the panelists for being here and helping me out to make the audience being more informative about the e-health infrastructure and the medical treatment beyond geographical boundaries. I would also thank the organizer for letting me be a moderator, and I now hand over this to Mr. Chandan.
Yes, thank you, Ms. Gouri. In fact, there is a question. Would you like to take that from the audience? Sanjay Modi is asking something. What needs to be addressed at this level is clinical governance. We have a system in the UK which I lead based on this matter. Would anybody like to elaborate on this?
I think Dr. Sujit sir would be the best person, and I know he heads a hospital which is one of the toughest clinical governance in India. So I think.
See, I thank you, sir, for letting me speak. Clinical governance based on what really? Our hospital, we have clinical pathways, which we had studied from the University of Cambridge in London, we had actually gone there. We had sent a team of 2 doctors, actually not a big team, but nevertheless, they came back with clinical pathways, and we have been following for the last 15 years, and we modified our clinical pathways, which is like clinical governance. For example, we have pathways for say orthopedic surgery. So therefore, from the time the patient enters to the time the patient is discharged, there is a pathway to be followed. And if one action in that pathway has not been taken, then in that case, the pathway stops and nothing progresses till that issue is addressed. Point in case is that if the nurse has not marked the site for the operation, then this point in the wait area of the operation theater, the patient will be arrested there, and there will be no progress further till the nurse who was in charge of the patient comes down, reconfirms, marks the site. This will be again counter confirmed by the nurse who's the circulating nurse in the operation theater, and only then the patient goes in, and then too on the table there is of course a checklist. So therefore these clinical pathways have helped us enormously as far as standardization of care is concerned. And we have been able to very effectively control the average length of stay of a patient to about 3.5 days for a single knee and 5.5 days for a bilateral, knee. And this is also for the hip. So therefore, there are multiple pathways like cesarean section pathway. There is the cataract surgery pathway. There is the primary angioplasty myocardial infarction, as well as stroke protocols. So therefore, everything being standardized, I think the quality of care improves. And here we also audit the clinical governance. So therefore, there is a lot of material which is thrown up. And if you have periodic meetings, then in that case, you find that if there is any deviation from pathways, it becomes a incident, and that incident is investigated by the concerned administrators. Thank you.
Well, great. Thank you so much, sir, for elaborating that question and giving a right, clarity on clinical governance. So, with this, we are through with the panel 2 session, and we have some great insights, great inputs from all the eminent speakers and the stalwarts of the hospitals which they are representing. And it's so much of expertise when it comes. It is definitely is an ocean of knowledge which we are trying to, we'll try to adjust and digest that, and definitely it will be giving a good way forward to the next panel speakers who are coming up with. So thank you so much, Aloke Mullick sir, for joining us at this forum today. Thank you so much, Mr. Bharath Kanji, for coming and giving your time over here. Dr. Sujit Chatterjee. So thank you so much, sir, for joining us over here. Samir sir, hats off to the efforts and the dedication. I saw you traveling, but that shows the spirit, how you don't want to miss the session. And we need to learn from the leaders like you. So every session is important. So thank you so much for joining us again over here. And definitely to Ms. Gouri Sardesai, she had to give a hard excuse because she's traveling. Maybe please do the honors back in team by felicitating them with a small token of thanks. A recognition to Dr. Aloke Mullick, the Group CEO of Omni Hospital, and a certificate of appreciation to you, sir. Thank you so much. Next.
Thank you, Chandan.
certificate is presented to Mr. Bharath Kanth Reddy, RY, the CEO of EIMS Hospital. Thank you so much, sir.
Thank you, Chandan.
This we are presenting to Dr. Sujit Chatterjee, the CEO of LH Hiranandani Hospital. Thank you so much for joining, sir. A small token of appreciation. We are presenting the certificate to Samir Mehta, sir.
Thanks a lot, Gouri. I think it was a good session.
Yes, and this goes to Gouri, sir.
Sujit and Aloke. So we always make good friends, but I don't visit them in their own city.
At this forum like this, it's all possible. So luckily, we are meeting each other with the smiling faces and a note of motivation for all of us that let's keep the flag hosting and move on.